social worker within 5 days of the admission, and then, as determined by the care plan, if a person has high levels of agitation and there's really psychosocial support that's needed, they will be going more often. Hospice chaplain within 7 days, although I can tell you that our chaplains try to make it there within 48 hours. The hospice medical director, who is the physician, will go as needed. They have to have something called a face-to-face visit for recertification. Otherwise, they're always available telephonically. One of the things that I didn't say that I should have said, it's probably later, is that there's a 24-hour on-call service. What that means is after hours, from 4 o'clock in the afternoon until 8:30 in the morning the next day, if you need to call after hours, there's somebody that picks up the phone. We have a live call center. You don't get a machine. You don't get a tape. You get a person. So if it was, God forbid, 2 o'clock in the morning and a person was having severe agitation or transitioning or whatever, they could actually triage a nurse to go out at 2 o'clock in the morning, or a physician, or a social worker, or a chaplain. So you're getting live 24/7 care.
Video conferencing.
What?
Video conferencing.
No, they don't do video conferencing, no. But that's interesting. I guess they might be able to. Then again, the patient in the middle of the night probably wouldn't be doing this type of thing. But there is full 24/7 support. What does hospice give you in addition to these people? Well, all disease-related medications, all of the medications are going to come to the home. They're all covered. There's no co-pays. There's no co-pays with hospice. Everything comes to the home. All of the durable medical equipment comes to the home. All of the medical supplies, oxygen for comfort, everything comes to the home. Air mattresses, anything you need comes to the home as long as it's related to the disease. Well, what does that mean? Well, let's say a person has a terminal disease, but they also have a chronic disease like diabetes. Well, the diabetes is not their hospice diagnosis. They're not on hospice because of diabetes. They're on hospice because of cancer or whatever. They're not going to get their diabetes medications under the hospice benefit. But they're still going to get it the way they always got it, through the regular way that they get their meds. So anything related to the hospice diagnosis, a person will be getting to their home. As I mentioned earlier when I described the inpatient level of care, it's really to control symptoms that are uncontrolled at home, and it allows a person to bypass going to the emergency room. Generally, when a person's on hospice, they don't want to go back to the hospital. That's part of what's going on, that they're tired of always going back to the hospital. They really just want to be in peace. They want to be cared for. They want to be in peace. They want to live in peace. They want to live with a quality of life, but they don't want to keep going back and forth to the hospital. So it helps bypass that emergency room situation. There's all kinds of different medical procedures that can be done in the home. You can have transfusions, although not in the home. There are medical procedures that you can have while on hospice. Some people might consider these heroic. These are things that we do. Generally, if something is considered a curative intervention or aggressive, that's the buzzword. If somebody says, if a hospice says, we don't provide aggressive treatments, well, different people describe it different ways. So, for example, some hospices will say, we will not let a patient have a blood transfusion. They're dying. Well, we do. We will let a person have a blood transfusion if they are symptomatic. We won't have somebody get a blood transfusion if they're not symptomatic, because there's no point. But there are some things that if a person wants, they will have it, because that's their choice. And as long as I said earlier, if it is not contraindicated, if it's not going to be more harmful than it is helpful, and it is consistent with their value system, we will let them have it. Hydration and nutrition is a big, big deal. And a lot of times I've been to a lot of presentations, and I've heard a lot of stories. And a lot of times when people say, and I hear this a lot, people say, well, I don't know how to fill out a living will. And I don't know if I check off a box today that says I don't want X, how do I know I'm not going to want that later? Or when you have those conversations with your children, or your best friend, or whoever it is that's going to be making decisions for you, if you can't make them for yourselves, you need to know that you could change your decisions. You're allowed to. Some of the treatments that we will allow are blood transfusions. In the home, a person could also do paracentesis if they're skilled, meaning that they can take out fluids if a person is swollen. Urinary catheterization. I remember when my mother would have hospice and she had a Foley catheter, right? She had the tube in a bag for her urine. It's very painful. And it really was a problem for her. It was very, very painful. And they taught me how to do a straight catheter. So I was able to ease my mother's burden and to empty her bladder by learning how to use that straight catheter, and we trained her bladder so it could be emptied fully a few times a day rather than the discomfort of having the Foley. So there's all different things that go on when a person is in that stage, and there's ways to care for them in a way that they can have a higher quality of life. That's what it's about, a higher quality of life. Continuous care, I explained to you. You're getting all of the extra level that you get in an inpatient unit, but you're having it at home, and it's in lieu of hospitalization for as long as you need it. The other thing that occurs when somebody's on hospice, because it's family-centered, it's holistic, is there are family meetings. I don't know how many people in this room have children, have extended family, or have no family. And there's probably some of all of those. Even if you don't have family, there are some people, I hope that you're blessed enough to have people that are close to you, that you trust, and that you talk to, and that you have spoken with about what you want, so that they can carry out your wishes for you if you can't carry them out for yourself, if you can't speak for yourself. If you have children, or spouses, or partners, or family that are very involved in your life, not all the time are the people who are involved in your life on the same page about what they would want for you if you couldn't speak for yourself. And that creates a whole another kind of a problem. So when there are different opinions about what to do for a patient, and it could get difficult, then one of the things that happens all the time in all hospices is we have a family meeting for goals of care to determine what are the goals of care. And that way, everything is surfaced and you arrive at what the goals of care and the care plan should be for that individual in agreement. It becomes also very important that whoever it is that you trust most in the world, and it doesn't necessarily have to be biologically based, but whoever it is that you trust to be able to do what you want, to carry out your wishes, is the person that you should designate to be what we call your healthcare agent, so that you can have confidence that what you want is going to be carried out. It's not always who you would think. And what about recertification of hospice? So how long is a person on hospice? Well, like I said earlier, you could be on hospice for 2 years. You could graduate off of hospice. We have had those situations where people actually get better and they go off. Eventually they may come back, but that happens too. So when a person comes on to hospice, they're coming on for a 90-day certification period. And then they can be recertified for the next 90 days. After that, every 60 days, a person needs to be recertified through a physician's face-to-face visit so that they can remain on the service. Some of the difficult but very important conversations to have are about advanced directives, DNR orders, healthcare proxies, living wills, and the end-of-life care planning. Those are very, very important conversations. Not everybody's ready to have them all the time. They're not easy to have. I always say, and I believe with 100% confidence and certainty, that the most difficult conversation is the one that you have with yourself first. If you can't have it with yourself, it's going to be very difficult for you to have it with other people. So there's a lot of reasons why people avoid or push off the conversation. It could be not wanting somebody to lose their will to live. It could be denying that a person is as ill as they are. It could be disagreements in families. It could be that you don't have a close relationship with whoever the logical people are that are going to be there. There could be any number of reasons, but you still have to have that conversation with yourself. And if it can't be with another person, let it be with your doctor. Doctors are important people too. If you go to any kind of a Y or part of a society or leagues or any membership organization, there's usually people there also that have assistants. Sometimes there are care managers, case managers, third parties who are not in the thick of things with families that don't agree are also good facilitators for those kinds of conversations. And they're just important to have. I'm not going to go into the next slide a great deal, which are the reasons to address end-of-life issues. There have been a lot of healthcare legislative changes in New York State since 2010. Some of these laws that have been passed are called the Palantir Information Act, which mandates now physicians to tell a patient of a terminal diagnosis and to offer options. That's not always easy for physicians either. I mean, we're talking about ourselves and our families. It's not easy for doctors either. Doctors are in the business to cure. It's not easy for a doctor to tell a patient that they've been caring for many years that they have a terminal diagnosis. Now they have to. There's something called the Family Healthcare Decisions Act, which mandates, it doesn't mandate, it puts in place a hierarchy of decision makers. So if you don't decide who you trust to speak for you, if you can't speak for yourself, New York State has already made a decision about who's going to speak for you. Better you should choose who should speak for you than somebody you don't know. Because at the end of the day, it could be someone in the hospital that doesn't really know you. And then there's something called the Palliative Care Access Act, which means that everybody must be made aware and have access to care options when they are seriously ill. What do you need to know if you ever want to make a referral for yourselves or for anyone else? We had a patient who made a referral for himself, and he directed his own care. He had no family. He had no close friends that he trusted, but he was very well aware, very cognizant of what was going on in his life, and he made a referral for himself. What do you need to make a referral? You need for your physician to be okay with it. You yourself need to be okay with it. If you can't make a decision for yourself, if you can't speak for yourself, a family member can speak for you. You need to provide basic demographic information, the name and contact information of the physician, insurance information, and you just need to make a phone call. And then the Access Center, which is the admissions department in any organization, will take over. And then what they do is they send out a nurse to evaluate the patient, and based on that evaluation, they tell the person or the family if they are appropriate for the care, and then it starts. And the last thing that I'm going to say about hospice is that you could go off. People jump on and off hospice. There's no penalty. A person could come onto hospice and then after a while feel that they're stronger. They got their appetite back, gained a little weight, they're not nauseous anymore, the sores went away, their hair grew back, whatever it is, and they want to give it another shot. And you know what? That's a good thing. And a person could go off of hospice, say, I want to try this treatment, I heard about an alternative treatment, I want to try it. Great. Try it. Do whatever you need to do. We're not going anywhere. I wish we were going someplace. If you need to come back, you can come back. There's no penalty. So hospice is a benefit. Don't think of it as a philosophy. Think of it as a government-supported benefit. You're entitled to it. Use it the way you can. Exploit it. Take advantage of it. And if you don't want it, get off. Nobody's going to be upset. You do what's right for you. And that's it. So if you have any questions, I'm here to answer them. And if not, please take some of our materials. My card is there if you want to call or ask questions at another time. And I hope you gained information that can be helpful to you.
Thank you very much.